So we'll go ahead and start. Hello, everyone, and thank you for joining us today on this webinar. I'm Dr. Eunice Ojo, the chair of AG Gerontology Research Interest and Implementation Group of the SNRS. So today's webinar is organized by our RIIG, AG Gerontology RIIG of the SNRS, and I want to say a few things about our RIIG. You can see my screen here. So a little bit about our strategic plan. We promote the advancement of research for the care of older individuals using innovative approaches to guide and promote the care of healthy, chronically ill, and frail older people. We facilitate networking opportunities and inspiration to nurses and other healthcare providers interested in aging research and aging care in the southern region of the U.S. So once again, I want to welcome everyone and thank you for making it to this webinar today. I'm sure we are all going to benefit from our great speakers today as they share with us. So in our RIIG, we meet on the fourth Wednesday of every other month. So as we are using our meeting time for today's webinar, the next time we're going to meet is going to be in July. And this year we have two webinars. The first one is holding today, and the second one is coming up in September. So we are going to send out information about that webinar as the time approaches. The other plan we have is to present at the 2026 SNRS conference like we did this year. And currently we have 4 topics for symposium topics that we are going to present on. And we have a minimum of 4 abstracts for each one. So we had already identified our corresponding authors, and they are going to be contacting the abstract contributors so we can put all this together and submit for presentation at the conference. So the conference is coming up in Texas next year between February 18th and 20th. So I appreciate everyone working on their abstract, and it's going to be, I believe we're all going to enjoy the conference. So our topic today for the webinar is utilizing AI and innovative technologies in aging research. We have 2 speakers. I'm going to introduce the first speaker. Our first speaker today is Dr. Stephanie Large. Dr. Stephanie Large is an adult health nurse practitioner. She graduated from Texas Women's University with a Ph.D. in nursing science, Emory University with an MSN, Duke University with a BSN, and Agnes Scott College with a BA in history. Her current practice is as a clinician for an epidemiological study and clinical trials in aging. While on the data team for the Health and Aging Brain Health Disparity Study, she facilitated the transition from paper charting to an electronic data capture system, reviewed data for quality, and assisted researchers with questions about the data. She is a founding faculty member of the University of North Texas Health Science Center's College of Nursing. Her interests include research intersecting aging and informatics, data methods, and working with students to develop research questions. I want to thank Dr. Large for presenting today. Now I will call on Dr. Parajeli to introduce the second speaker.
Hello, everyone. I am one of the co-chairs of this RIIG. Nice to meet all of you. Now I'm going to introduce our second speaker for today, Dr. Nisha Mathews. Dr. Nisha Mathews is an assistant professor of nursing at the University of Houston, Clear Lake, Texas, where she teaches nursing education and leadership for the MSN program and RN to BSN program. She has been selected as a professional member of the National Academics of Practice 2025. the immediate past chair of the Research Grants Committee of the National Association of Indian Nurses of America 23-24, Dr. Mathews currently serves as the chair of the editorial committee of the National Association of Indian Nurses of America. Dr. Mathews is a Sigma Theta Tau International Honor Society of Nursing Academic Leadership Academy Scholar. Dr. Mathews is the recipient of the 2024 Sigma Theta Tau International American Nurses Credentialing Center Evidence-Based Practice Implementation Grant. Dr. Mathews is one of the grant recipients and champions of ANA-CDC Project First Line, American Nurses Association Infection Prevention and Control Content Dissemination Funding Opportunity. Thank you, Dr. Mathews, for being a second speaker for today's event. We look forward to both of your talks. Thank you.
All right, can I go ahead and share? I'm going to share my screen.
Yes, please.
So
Let me take, yeah, I'm going to take this down, then you go ahead and, yes.
Screen share, okay. Hi, I'm Dr. Steph Large, and let's make sure we guys can you guys see my screen? Everybody see it?
Yes.
Okay, excellent. What Dr. Mathews and I are going to be doing is we're talking about utilizing AI and innovative technologies in aging research. We represent University of Houston Clear Lake and the University of North Texas Health Science Center's College of Nursing. Let's see if it'll click. Hang on. All right, we have no conflicts of interest. Our objectives are to describe early detection and diagnosis, discuss personalized care and interventions, examine healthcare system factors in older adults, review equity and access, and explore nurse training and education. Introducing it, the population of older adults is growing, and many older adult care needs are not adequately or equitably met. Emerging technologies have the potential to improve the health and care of older adults. Examples of artificial intelligence is utilized in designing models, for example, fall prediction, to enhancing social engagement. And I'm going to turn it over to Dr. Mathews.
Thank you, Dr. Large. So when talking about early detection and diagnosis with AI enables early detection by certain features, pattern recognition. So AI algorithms can analyze medical images like X-rays, MRIs, CT scans, and patient records to identify patterns and anomalies associated with diseases, even in their early stages. And machine learning can analyze, machine learning algorithms can be trained to predict the likelihood of a patient developing a specific disease based on various factors such as genetics, lifestyle, and medical history. So that comes under predictive modeling. Personalized screening. AI can help tailor screening and diagnostic tests to individual patients based on their unique risk profiles and genetic predispositions. When talking about data analysis, AI can quickly process and analyze large data sets, identifying subtle biomarkers or indicators that may be indicative of diseases. And of course, that's going to really help with the prognosis and quick recovery, or I would say early recovery. Increased accuracy, AI algorithms can surpass human capabilities in recognizing subtle patterns leading to more accurate diagnosis. Faster diagnosis, AI can analyze data more quickly than humans, potentially leading to quicker diagnosis and treatment decisions. So less chance of errors compared to human brains. And improved outcomes. Early detection allows for timely interventions, which can significantly improve treatment outcomes for various diseases, including cancer. Like certain cancers are caught on early stages, there will be better prognosis. And reduced human errors, AI can help reduce the risk of human error in diagnoses, leading to more reliable results. Personalized medicine, AI can be used to develop personalized treatment plans based on individual patient characteristics. Some of the examples of AI applications in early detection, cancer detection, like AI is being used to analyze medical images and patient records to detect early signs of various cancers that include lung, breast, and colon cancer. Heart disease, AI can analyze ECG data and other patient information to identify early markers of heart disease and stroke risk factors, again, helping reducing the disabilities or after effects in a much significant manner. Neurological disorders, AI can be used to analyze brain imaging data to detect subtle signs of neurodegenerative diseases like Alzheimer's and Parkinson's. Talking about diabetes, AI can help detect diabetic neuropathy and other diabetic complications early on. So again, that will help with timely interventions. Rare diseases. AI-powered tools can help doctors identify rare diseases by analyzing patient records and identifying subtle patterns. So next slide, please.
Okay.
Thank you. So
You're welcome.
personalized care and interventions. Some of the factors we will discuss: individual factors, quality of life, combating social isolation. When we say individual factors, these are interventions that are finely tuned to factors such as environment, personal history, behavioral patterns, and new evidence. And personalized care has proven to increase engagement and improve outcomes. And that also include precise or precision care. Precision in care can lead to better health outcomes, especially in aging research. Personalized care can leverage a wide array of data points, such as AI can use the genetic information, treatment history, lifestyle factors, and even real-time feedback using the devices or mobile health apps. And certain AI tools can recognize speech patterns, social media posts, biometric data. When we talk about older adults, we need to talk about combating social isolation too. So AI can be used or can help older adults or geriatric population connect with family and friends via video chats, engage with others by taking remote learning and exercise classes. And of course, AI is going to help with bridging geographical distances with meetup social clubs located in other areas of the globe. And again, these older adults, older adults can use, or the providers can use, or the customers or consumers can use the therapist, care providers, doctors, and interdisciplinary team can be communicated, or they can communicate with the older adults and they can help with combating social isolation when talking about treatment management. Next slide, please.
Okay.
The potential benefits of AI in elder care. So some other features we want to discuss are health monitoring, customized care, independent living. So health monitoring, we can talk about remote patient monitoring. AI in health monitoring uses vast amounts of healthcare data, identifying patterns, predicting potential health issues, enhancing early interventions. And there can be real-time monitoring, and we can use AI for medication adherence, tailored communication, and independent living, particularly for seniors and individuals with disabilities. Like there can be smart home technology, communication for social engagement, health management, and assistive technology. So all these can be helped with independent living. So in addition to using AI to personalize disease risk, disease trajectories, or treatment response, AI can also personalize communication and education. AI to integrate and synthesize information. Disseminating the information through clinician support can improve access.
All
Stephanie,
right. Yeah, so I'm going to be talking about healthcare system factors for older adults. I will specifically be talking about generative AI. It is a machine learning technology. What is machine learning technology? It is using algorithms to review data. It identifies patterns, and then it can make predictions and decisions. This creates, quote unquote, new data. Currently, though, we're looking at how do we integrate artificial intelligence into the healthcare workforce and how do we use it? What's the starting point for pattern identifications? What patterns matter and which patterns are important? Because causation and correlation are different. For predictions and decisions, what are the most important or valuable that we think matter? What predictions are important? And when we predict, what do you then do with that information? Assessment and outcomes. This is the new area. This is where it's truly growing because how do we assess the AI outcomes? We need valid measurements and valid tools for assessment. If the tool measuring the outcome isn't valid, you don't know if it's working or not. And then what outcomes are important? For example, how do we address changes in outcomes? We have hospital A, hospital system A. They look at it, they use all of their data, and they say, hypertension is the predictor. Stop. We have to fix hypertension. Well, what happens? Hospital system A buys hospital system B. The data is merged. All of a sudden, what happens when hypertension is no longer a predictor? What do we do? What are the consequences of those actions? And how do we, kind of like clinical guidelines, how do we adapt and adjust them based on the artificial intelligence model? We don't know that yet. This is all being discovered. An example of use. What I'm using is an article by Reddy called Generative AI in Healthcare, an Implementation Science-Informed Translational Path on Application, Integration, and Governance. And I've made a mistake in the slide, and I will talk about that because it goes to language and what language across technology and language across disciplines is important. For generative AI models, one example is a generative adversarial network called GAN. And this is what creates a generator. The generator makes up fake data that's good enough to pass the discriminator. The discriminator is a side that says, hey, tells you data is fake or data is real. And as you keep going on time, as time goes further, we have an iteration of the generator becomes better at creating fake data, and the discriminator gets better at telling or distinguishing between fake and real. Large language models. The large language models and autoregressive models are actually the same thing, similar terminology. These are the familiar. This is ChatGPT as an example. It's the one I use a lot. It predicts the next thing based on prior knowledge. The great thing about it is that it can perform many language tasks and language processing very quickly. Types of data in artificial intelligence include text, images, and other types of data. The application part that I'm going to be discussing specifically are medical diagnosis, clinical documentation, and personalized medicine. All right, medical diagnosis. Large language or learning models can almost pass medical exams. They're almost to the point of answering the right multiple choice question test, right? Electronic health records are vast repositories, but they're not limitless. Part of what's important about electronic health records is who owns data. They're proprietary. We can't always share it. They don't always talk to each other. And the data isn't always the same and compatible. Older adults, a lot of times, have records that are not in electronic health records. They're not in the EHR. When I started in nursing in about 2007, we were still working in the hospital on paper-based charts. A lot of nursing homes or long-term care facilities are still using paper-based charting systems. Those don't get talked to the models. They're not integrated into the models. This for older adults, what's missing in the model? How many records aren't available in the EHR? Next question, though, is how important is that data? Does it matter? Is it important? How do we get it integrated if you can't get all of it integrated? And how do you ensure the accuracy? The next question that's still being decided and still will be decided is who's liable for the misdiagnosis? Is it the designer? Is it the provider? Who is it? This will likely take time, and this, as the technology develops, expect the legal system to catch up, and they'll be going back and forth, and we'll have to see where the liability is. But it's something to be considered as you develop interventions. Who's responsible for either that action or inaction? Clinical documentation. This is where we generate reports and summaries of vast amounts of data. Great. Older adults have multiple procedures, exams, and clinical notes. A great place is to provide draft summaries. I'm going to walk through a ChatGPT example. This is just when I played with it, and this is one snapshot. Say it's a hospitalization overview, January 2023, CHF exacerbation, admitted for worsening dyspnea and lower extremity edema. Hang on, I'm letting someone in real quick. Required IV diuretics, telemetry monitoring, discharged after 4 days on optimized heart failure regime. Each discipline in the summary is going to value different information. Cardiology, respiratory, nursing, physical therapy. Another part of the summary data is what's important across time. Some information is going to be very important, say a pericardial effusion is going to be very important in the summary as you're going through the visit. Isn't necessarily important in all the steps leading to the pericardial effusion 10 admissions later. What does that summary look like, and how is it discipline specific? We'll have to likely train the AI, the artificial intelligence component, to understand that and understand the nuances, because we're all going to value different information, what's important in the snapshot. Personalized medicine. I'm going to actually have a quick personal opinion before I get into this. Genetics is what you see a lot here. And genetics is common, but it's more complicated than that. It's the genes make proteins. What we're learning is the genetic interaction with the environment is key. Now, for some groups and for some specific illnesses, genetics will dictate the personalized treatment plan, but we haven't gotten there yet. A great example would be the thing that was talked about when I was in college was, hey, let's get a genetic test for how quickly you metabolize a medication. That would be great. That's a very specific component. More difficult is when multiple genes interact, and when you have the interaction from genetic in vivo as you interact through the environment at different stages in your life. The Ready article starts with an example of mental health. We're going to build upon that and put it into the context of older adults. Personalized therapy. For example, an artificial intelligence creates a scenario for anxiety. It guides the patient through the interaction. In older adults, medication therapy management is important. Managing medications is critical. They have a lot of medications, and they have different home environments. The AI can create a scenario for medication management and guide a patient through how to take their medications, giving them practice and pointers. Key, though, is designing a prompt and including data that is valuable and personalized to that person. There's a lot of areas that you can develop in terms of what information about the home environment or about that person specifically can create a good training tool. The artificial intelligence can take those data components and build it. And looking at, what do older adults need? What do you need practice doing? Next, we're moving on to equity and access. The aim is to ensure that data in the model is equitable. Governance and evaluation frameworks, these are still being developed and discussed. We're still debating on what matters. At the system level, the RIIG article recommends that depending on where you work and how large it is, you have a committee, you develop policies and guidelines, data management, who manages the data, who's responsible for the data, how do you keep it, how do you store it, rectifying inaccurate data. That's critical, but who's responsible for it? Who's responsible for the inaccurate data? Who's responsible for fixing it? And then notifying folks that, hey, the data we gave you is wrong. Risk assessment. What types of personnel are able to adequately assess risk? Who are the people in your organization that understand and know this and can translate this new knowledge into a new area where we're still learning about risk? And how do you manage risk in a way that doesn't harm people or patients? Hang on. Okay. All right. What I really like to do is discuss ChatGPT outputs and use them to begin a conversation. This is bias. It's also known as equity via ChatGPT. There are no right or wrong answers. It's discussing the output, and there is some overlap between equity and access in the slides. And we're going to take, and what I asked ChatGPT was equity via older adults and equity via nurses. ChatGPT says in data, training data sets don't include those 75 and up. And there is a limited inclusion of frail elders. Question then is, how are frail older adults different from healthy older adults? And are we frail by physical ability or cognition? Next is algorithmic. If you don't have the data is not available, you don't have a good predictor. You have bias in the model. A large bias with older adults is that age is considered a negative factor. Age increases risk because we've lived longer, we've had chances physiologically to change, to have our bodies wear out through either the types of work we're doing, the environment that we've encountered, the risks that we've taken. Accessibility. A big assumption when you use ChatGPT is that digital literacy is not typical of older adults. Is that really true, though? Or is that a stereotype? Interface design, visual, hearing, and cognitive impairment. Next question is, where's the intersection of cognitive impairment versus health literacy? When you do a neuropsychological test, you control for age and education. Why? Because education allows us to have the language ability to process and to navigate the world. Next, systemic and structural biases. The algorithm could deprioritize costly or long-term care. Now, to a certain extent, that's already being done. It's part of the risk assessment. And how much does the AI model value the intervention and the cost versus the quality of life improvement? Ethically, this is resource allocation, age-based assumptions, and we saw a lot of this in COVID. Who gets the ICU bed? In a limited resource environment, where do the resources go? Next, we'll move on to nurses. Role underrepresentation. The artificial intelligence tools focus on provider decision-making, what the ChatGPT example is care coordination and advocacy are not utilized in the AI. Is that all that nurses do? Is that the part that's missing? And it's not just nursing. Included in that would likely be PT, OT speech. What information is not incorporated in healthcare roles? Workflow disruption. This is one that is likely a complaint across disciplines. Clinical actions don't necessarily align with nursing judgment or workflow. Now, an argument that we can make is that this is occurring already, but the AI exacerbates the current problem. If we're going to use the technology, why are we allowing it to exacerbate or build on a problem that we already have? Data capture. According to ChatGPT, the unstructured nature of nursing notes means that the AI can't analyze it well. And how do you estimate acuity if the nursing actions or inputs aren't captured and if they're not valued by the model? Professional bias. Currently, nurses are not well trained in AI tools. Nisha will be talking about how we improve this. The evaluation bias, too, is the metrics might not account for nursing sensitive outcomes. What did ChatGPT say nursing sensitive outcomes were? Comfort, education, or emotional well being. Is that all that nurses do? For example, for me, I was recently an observation patient in an acute care setting. How much education can you actually do? And how do you capture that in the snapshot when I'm leaving, when I'm actively recovering and, less than 24 hours out of anesthesia? The next one that we're going to move to is access via ChatGPT. Again, so I asked this. Again, you'll see some similarities and you'll see some differences because access and equity are slightly different. We have the digital divide. It repeats only in terms of access. We're talking about patient portal, smartphones, and high-speed internet. Is the digital divide, though, really older adults, or is this a socioeconomic indicator and a where are you in access versus age? Interface design. Again, it's similar. It's smaller text, rapid navigation, complex language. Key component, though, is in normal aging, we have some slowing in the multitask complex attention ability. If the AI doesn't understand that when we're designing the interface, we need to control for that and we need to build it, it's important. What do older adults need? Missing in terms of the interface design, though, is the physical component of interface design. When you ask how sensitive the buttons are. For example, my grandmother got to in her 80s, was able to learn how to use a computer. She couldn't use a mouse, though, because she'd had damage to her right index finger. But she was able to use a trackpad, much easier. She could use her other fingers to navigate. Cognitive and sensory. These are vision, hearing, and memory. These are the accessibility accommodations that we really should be controlling models and having them incorporate that information. But how do you include it? How do you include it in the model? How do you train the algorithm? What information does it have access to? The care setting disparity. AI tool availability tends to be in ChatGPT, I think got this right, in urban and academic medical centers. It's not used as much in long-term care, rural or home-based settings. How do we incorporate that transition from acute care to long-term and back is an area that we know is important and valuable for us to train the model. That's where we know people keep coming back because of missed components. What are the differences? Consent and understanding. Older adults, according to ChatGPT, might have difficulty understanding how data is used and may not make informed decisions. How do we consent adults into AI modeling? Also, though, where is the consent when we're using the data? How are we informing patients in those models when we're gathering the research or when you're working with AI? Moving on to nurses, we have the role exclusion. Limited input from nurses. Again, what other specialties are missing? We need to encompass and we need to have AI include the nursing workflow. According to ChatGPT, bedside care and handoffs are part of or the examples. It's more than that, but what are the critical pieces, right? Training, Nisha's going to talk about that. Equipment availability. When I asked ChatGPT this, and when ChatGPT spits it out, you see the bias towards the acute care setting. It said that AI technology was not available on all floors, and that clinical support, decision support tools, and smart vitals monitors weren't included on every floor. Who do you need it? Who has the priority? Those tools would be great in long-term care settings. It's not just floor-based, it's who has access to it, who can afford it, and who can maintain the algorithm so it continues to update. Finally, when nurses are limited in terms of voice in the AI design, this leads to tools that don't incorporate nursing needs and expertise. We've seen this with the transition from paper-based to electronic healthcare, the electronic record. Nurses need to be at the forefront and our voices need to be heard. And now I'm going to pass it on to Nisha.
Thank you, Stephanie. So under nursing training and education, we have got a lot of opportunities. So talking about simulation and virtual learning, AI has the potential to supercharge simulation by offering scenarios that are realistic and tailored to students' individual learning needs. So some of the examples could be AI-enhanced robots that can interact with nursing students in a way that is like more realistic than our high fidelity mannequins. And AI can create scenarios like medical emergencies and student can intervene, and that will be like much harder in real life situation. And simulation scenarios might include medical emergencies where nursing students could practice skills that might not work very well in the real setting. And another could be like virtual exploration of various social determinants of health to eliminate challenges that individuals and populations may encounter. For example, like I want to say, we have created a study crafter game for students using our using our gaming students and our psychology faculty. So in that, the students, as a part of interdisciplinary effort, they created a game, study crafter game, and in that, students are creating games using different scenarios. For example, like access to health care and maternal SDOH factors. So these are certain situations, these are certain AI uses we can use for students. And when we say access to healthcare, nutritious food, safe housing, like in certain areas where students are practicing, like they don't have the exposure to certain population. And we can have that population or patients created using AI, so that way students have that exposure. And nurse educators can work with community and cultural leaders to develop AI-enriched videos where students can immerse themselves in different areas to gain unique regional and cultural perspectives in the state. Enhanced clinical judgment tools. So, as we know, we already have some clinical judgment tools existing out there. So, this application of AI allowing students to provide more timely and appropriate interventions informed by AI-generated predictions and clinical care suggestions. For example, a new AI-enhanced clinical decision support tool rapidly generating nursing diagnoses, calculate patient fall risk predictions, and develop decision trees to prevent catheter-associated infection. While nurses can carry out these functions without AI, the new AI tools have the advantage of being able to rapidly analyze large volumes of data and then automate the adjustment of risk calculations. Talking about personalized learning, AI has the potential to transform education as an individualized tutor for students. AI tutors are there, like Khan Migo model developed by the Khan Academy. So there are like nursing tutors, AI tutors. They can walk students through a simulated patient interview or provide instantaneous feedback on assignments such as drafting clinical documentation or calculating medical dosages. Next slide, please. Thank you. So, like Stephanie mentioned, who is accountable? So, the American Nurses Association recently published a position paper on the ethical use of AI in nursing practice that emphasizes the need for ensuring transparency, eliminating bias, preventing health disparities, and protecting patient privacy and confidentiality. So we have to make sure the consent parties there, and the nurse educators have to make sure that we have to double check the data. Like, for example, I want to give a simple example here. Like, you are asking a student to create a case study on renal failure, and the student is creating it using AI. But of course, we have to make sure the student is also checking the literature out there to make sure the data is correct and there is like no issues there. Most importantly, nurses must ensure AI does not compromise the caring, compassion, and human relationships that are central to nursing. So, nurses have to remember that advanced technologies do not compromise the nature of human interactions and relationships central to the nursing profession. And nurses also remember or accountable that systems and technologies that assist in clinical practice are urgent too. They are not replacements for the nurse's knowledge and skill. Therefore, nurses are accountable for their practice even in the instances of system or technology failure. Again, ANA argued or mentioned strongly suggested advances in technology, genetics, and environmental science require robust responses from nurses working together with other health professionals for creative solutions and innovative approaches that are ethical, respectful of human rights, and equitable in reducing health disparities. We also have other resources like the Nursing and Artificial Intelligence Leadership Collaborative is another group that has developed strategies for nurses to take leadership roles in shaping the use of AI in health systems and nursing practice. Please go to the next slide, Stephanie. Thank you. So the summary is integration of AI in practice must not alter the goals of patient care. Compassion, trust, and caring are foundational principles in the nurse-patient relationship, especially when caring for older adults. The continually evolving of advanced digital technologies such as AI must be adopted or integrated into nursing practice within these nursing and ethical care elements so that nursing practice remains relevant in the changing landscape. And AI is a broad category that involves using algorithms to drive the behavior of different agents, such as software programs, machines, robotics, games, and other hardware devices. So ultimately, nurses are responsible. Whenever we are using AI, we should know the liability factors, and we should always ensure there is the human component. Stephanie, you want to add something? Thank you.
Yeah, I think one of the important things is that this is evolving, and the other parts is that the data and the algorithms is going to be different depending on where you work and what you have access to. Another component is how accurate is the data that you're measuring? How many times do we have errors in the electronic health record that go forward And does that actually change the model? And notice that this is a new and evolving area. It's a lot of fun. It's really interesting, but we also have to learn the terminology that's used by some of the information scientists. And Nisha, do we want to move forward to the thank you slide?
Yes, you can. And only thing like I want to add, it is essential for nurses to be part of the interdisciplinary effort to advocate for an AI governance framework and develop regulatory guidelines. So nurses have to be at the table and make sure that nurses' voices are heard whenever policies are made regarding AI and nursing.
Exactly. Agreed.
Thank you.
All right, references, and then thank you guys. We really appreciate it. I'm going to stop sharing and hand it over to Eunice. Oh, and hey, Dr. Sario, who's another TWU
Hi,
rep.
Dr. Cesario. So good to see you here.
Yes.
Thank
Rocking
you
on
so
to my
much.
to my alma
Wonderful.
mater. All right. Eunice,
Oh,
you are now in charge.
okay,
So
no problem. Thank you so much. I want to thank our speakers, Dr. Large and Dr. Mathews, for such a great, informative, and quality presentation today. We appreciate your time and sharing your knowledge with us. Thank you so much. We still have a few minutes. Would you like to take some questions, please? Can you take questions?
yes. Oh yeah. I love questions.
Okay. All right. So does anyone have questions for our speakers today? Questions from the audience?
Just both of you are educators. How are you including this information with our new up and coming, undergraduate students? How are you doing that? Are you doing that in every class? Do you have a special class about this? But I think it's essential that everyone know about it and, the aging population or any population. So what are you doing as educators to make sure our new generation of nurses have this?
Go ahead. Go, Nisha. You can go first.
Thank you, Stephanie. Thank you for that question, Dr. Cesario. So for the AI part, we are using it in our MSN Education and Leadership program. So for the research class, we have to make sure that our students work with gaming faculty and gaming students, and they create a game. Like that is one of their objectives for that class. They have to create a study crafter game with the gaming faculty using SDOH or certain topics of their preferences. We give them a list of topics, and then like they have to create a case study, and then they have to create the curriculum for undergraduate nursing students, and then they will also create the gaming part. That way they get that artificial intelligence component.
Okay, so for me, I think I at some point will be teaching undergrad yet. I'm not sure yet. But for me, I use ChatGPT. I use it for course development a lot. We're a new college of nursing, so we're building it. In our informatics class at the master's level, we have students using AI and having a discussion board and critiquing it. We also are, and when I'm also going to be developing a chronic disease concentration, and at some point in the fourth class, we'll be talking about artificial intelligence. It's a lot of, I think, learning what that is and what the important language components are, and also explaining to students that it's a starting point, not an end. And the other part is that training educators to utilize this. How do you utilize it in a way and being open to change? As education changes, our tools should change, but you have to get used to using it. If you write a bad prompt in the AI, it's going to spit out something bad. It's got to be an iterative piece. That's all I have to. I'm trying to be quick.
Thank you. It's so important. I think, the technology is growing so fast. Everybody needs to get caught up on it. New nurses, experienced nurses, teachers.
I agree. And then if you look it up, don't use the AI to look up stuff, Because the other part that we need to really explain is, and this is still being worked out, is that the copyright. The copyright doesn't belong in the AI. What's missing from the model? It's all on where it's built and who do you have access to it? Meaning you can't just pull an article and dump it in the AI because then the AI owns it. Also, anytime you use the artificial intelligence piece, they own what you've done.
So Eunice, if I may, I want to share what we are doing at Georgia State University. We have a overall large project as a collaboration with the Learning Science Center. And Learning Science Center already introduced a lot of good AI tools that can be implemented to nursing education. But the important part is that all those tools are developed for like bench science or something very generic. So we do really need some refinement processes, meaning that all those tools should be refined appropriate for nursing education. So at this moment, we have been collecting data by using these AI tools in very first, courses in the undergraduate students. And that has been very successful. We have used the AI tutor, which is Jean Watson. Jean Watson is our AI tutor. And we also use the Smart Nurse. Smart Nurse is something that it's a very conversational. The students can ask questions, ask help for completing their writing assignment, so on and so forth. So far, the sign is that there is a huge potential to grow. What I wanted to make a point here is that we can rely on AI technology, deep learning and everything, but most of all, very important thing is that we need to make sure that those tools are valid for nursing. So that's what I want to share. Our project will move on, and there are a lot of good federal, federal funding, which is a very significant amount. But the key for success is collaboration with those people, because nurses are not the AI tool developer. We are not trained to do so. But collaboration is something that we can do. We can lead those collaborations.
Thank you so much. Thank you. Do we have any other question? I'm looking at the chart and I see people sending messages. Thank you for a nice summary of the AI utilization. Thank you for such an important topic. Thank you. Great presentations, everyone. Thank you, everyone. Thank you. Good presentation. So just to let you know, you did an amazing job today. Thank you to our presenters. We still have a few minutes if anyone else has any questions.
I would
I'm
just
sure.
say that
Good.
I'm sorry, I'm just going to say that it's an important tool to use and you can use it, but we're growing. And as people have said, if nurses aren't at the table, what's going to happen is that our voice will be missed, like it was in a lot of the electronic health record implementations. And if the nursing data isn't captured, how do we say what we do is important?
I absolutely agree with Dr. Lars. There is even a paper that says that nurses do resist to any new technology when they are not included in a development process. So nurses should be in the team for sure, even from the beginning.
Okay. Do we have any more questions from the audience?
If not, feel free to reach out to me or Nisha. Yeah, like seriously,
Yes. And one
Yeah.
of the participants asked for the references. So I got the email. I will send the references to that email address. Yes.
Thank you so much.
You're welcome. and looking forward to talking to you or more
Absolutely.
collaboration.
Sure, absolutely. This is a wonderful group. Thank you so much, Eunice, for organizing this webinar. Thank you.
Thank you, Eunice
Thank
and
you.
Josna, for the opportunity.
Yeah,
Thank you
thanks,
both.
Eunice.
It
This was
such a
fun.
great presentation. Thank you.
Thank you. Wonderful job.
All right. Well, if not,
Thank you,
y'all.
everyone.
Thank you.
Bye, guys.
To
I'll see you
our,
all next.
to
Bye,
our
guys.
members,
Bye.
Aging and
Bye.
Gerontology RIIG, please, if you are submitting an abstract, please work with your corresponding authors to make sure that we combine all the abstracts and we submit in time for
Okay,
presentation.
absolutely. Thanks, guys.
Thank
Thank you, everybody. Good job.
Bye, guys.
to our
Thank you.
speakers.
Bye.
Bye, guys.
Can you stop the recording? Thank you.
Sure. Let's see. Hold on one second.